welcome to NOAA Round 7, Session 4. My name is Negar Azadlar, and I will be facilitating this session. Please join me in welcoming our presenter, Dr. Stephenson Strobel. Dr. Strobel is a health economist and holds a Ph.D. in public policy from the Brooks School of Public Policy at Cornell University. He is a trained family physician, having completed a residency at the University of Toronto, and practices as an emergency medicine physician. He is currently a postdoctoral research associate at the Weill Cornell Medicine Department of Population Health Sciences within the Division of Health Policy and Economics. He has research interests in health economics, organization of healthcare systems, and physician behavior. Today's topic is access, health, and wealth, the short and long run effects of the Saskatchewan municipal physician system on rural access to physicians, health improvements, and economic well-being, which examines the effect of physician access by leveraging a historical medical program created in the province of Saskatchewan called the Municipal Doctor System, and evaluates the impacts of hiring a physician in the 20th century on current access to rural physicians. The results of this work speak to current policies on rural physician retention, as well as the impacts of physicians on the health and wealth of communities. Before we begin, I'll go over some event housekeeping. Participants will be muted throughout the webinar. To submit any questions during the webinar, please use the Q&A function. Just a friendly reminder that the Q&A function is different from the chat function. The Q&A answering your questions will be facilitated during the final 20 minutes of the webinar. Thank you again for joining us. I will now hand over to Dr. Strobel.
Hi there, and thank you so much for that great introduction. Just to sort of tell you guys a little bit about myself. So my name's Stephenson. I'm a postdoc at Weill Cornell Medicine. I'm a health economist, and I'm also a physician. And this is joint work with Sean Nicholson, who was one of my PhD supervisors at Cornell, and Maggie Yee, who is a PhD student at Berkeley right now. And this really is about, as the title suggests, access, health, and wealth, the short and long-run effects of the Saskatchewan Municipal Doctors Program on access to physicians' health and economic well-being. Certainly, this is a work in progress, and so I'm very happy to hear any feedback that you'd have about the presentation, as well. All of the sort of mistakes, errors, typos are, of course, my fault rather than my co-authors. But to sort of give you some very quick motivation about the topic, this is an article that I just pulled, off of the internet last week about the difficulties of rural areas in Canada recruiting and retaining family physicians. And this is not only a family physician issue, but this is sort of a more general access to medicine kind of issue where certainly it's been very common in the news to hear about ER closures in rural areas, very lengthy wait times to access family doctors, if you even have one, and then sort of millions and millions of Canadians not being able to access a family physician, period. And so the motivation here really is that, particularly now, but really, historically, it's always been an issue in Canada and in other places to retain and place physicians in rural areas. And so it's a humongous focus of public policy in Canada. So, there are some StatsCan figures that suggest that, physicians alone, there will be about 40,000, shortfall of about 40,000 physicians within Canada by 2028. This is especially concerning for rural areas. So, current estimates suggest that, about 8% of the physician workforce services about 20% of the total population in rural areas. So a great disparity in terms of access in these places. And, these statistics need to be taken a little bit with a grain of salt, but, recruitment of physicians is an extremely expensive and onerous process. So, this is an American company that puts out these figures, but the hard costs, like giving the physician an incentive to come to the community, covering their loans, paying for their clinic, things like that can be as expensive as $100,000 to $200,000 alone. And that ignores, in the United States, at least, that sort of ignores partly, the revenue generated by the physician, which is sort of less important in Canada. But this is all to say that this is a really, really huge expense to get physicians into places. in rural Canada. And so again, to that idea, Alberta itself is spending about $260 million over 4 years in order to recruit and retain physicians across the province. And this is a similar problem everywhere. So, motivation number one for this project really was like, there's a huge shortfall of physicians. It's an extremely important public policy question to try and get physicians into rural areas. How do we do that well? And what does it look like when we get a physician into that area? Really the next sort of motivation behind this is, we hope anyway, that physicians actually impact health for people in these areas. So, there is a very large literature out there on correlations between physician density and access to testing and treatment. To a certain extent, this literature, especially in the economics literature, is really motivated by this idea of induced demand effects. Basically, physicians are sort of pushing services on patients in order to get them to use those sort of services. But really, there is a fair amount of this. So this Gruber and Owings paper is a very classic paper on obstetricians and whether or not they use cesarean sections when their sort of practices are negatively impacted, in terms of their incomes. But there is this other sort of strain in this literature that does actually suggest that, when you get access to a physician, especially in rural areas, there is this just pent up demand for better care. And so this Carlson Gritton paper is from Norway. The Schauman's paper is from Belgium, and they both show that like once you get a physician into an underserviced area, patients get better access. It's as simple as that. There are actually some more mixed results actually with some types of program intervention. So this Markowski paper actually examines basically a very similar program to the one that I'll be talking about, where in the 1960s and 70s, the United States government actually tried to get physicians into underserviced areas. And they look at Texas and basically find that there's no huge impact in terms of access to these physicians in these rural areas within Texas. And there's really no effect on mortality. But there is some sort of more recent literature on at least kind of, instead of this binary 1-0 sort of you get a physician or you don't, better physicians certainly seem to produce better health and at a lower cost. And so this Fletcher and et al. And Doyle paper both suggest those things. All of this is to say that, again, there's very good logic, but there's also very good evidence that suggests that you get physicians into certain places, patients can access a physician, and they get better health. And then finally, health in itself is sort of a consumption good. We think at least patients gain benefits from health itself. But the other thing that physicians would like to think do is improve health in order to improve economic outcomes. People become more productive when they become more healthy. That at least is some of the thought behind why we want to, get physicians into rural areas. And so there are, quite a number of studies on the link between access to healthcare and economic outcomes. So this Levi and Meltzer paper is a review basically. But interestingly, there really isn't hugely good causal kind of studies on, in the classic sense, want to randomize a physician to a patient. Does the person who gets randomized to the physician get better as a result relative to the patient who doesn't get randomized that physician? There are sort of some other studies. The Finkelstein et al. Paper in QJE is obviously the sort of a touch point paper that looks at the Oregon Health experiment, and at least shows that when you get access to health insurance, that your mental and physical health does improve, although it doesn't directly sort of speak to the idea of the physician. And then there's some other sort of studies here that also suggest sort of mixed evidence in that, access to, ART drugs, for example, for HIV, improve food security. Again, it's a very credibly causal paper here where, people are getting antiretroviral therapy and suddenly their food insecurity goes way down, which again suggests that perhaps there is this economic kind of connection between health and economic outcomes. And so that brings us kind of to our research questions today that we're hoping to answer with this paper. The first one is, does hiring of physicians change long-term access to those physicians? And in particular, we're going to focus on rural areas in the province of Saskatchewan for this. The second question that we're hoping to answer is, does hiring of physicians change short to medium run health outcomes? And so we'll look at a couple of health outcomes. When a physician is hired into a local community, what happens to kind of deaths in particular in that community? And then does hiring of physicians change economic outcomes? And so we're going to look at, the major sort of sphere of economic activity in the province of Saskatchewan, which is again our kind of our place where we're going to examine is that of agriculture, very heavily agricultural province. And so we're going to look at a number of agricultural outcomes, but also a number of tax outcomes to sort of build this case that that these are in fact impacted by access to a physician. And so to give you kind of an overview of the paper here, the methods, we're going to leverage this policy experiment that occurred in the early 20th century. And at this time, this was pre-1961, so this was pre-Medicare in Canada. And the way that healthcare works in Saskatchewan at the time period in sort of the 1920s and 1930s is that you would be a patient and you would directly pay your physician. So you would go to the physician and directly pay them out of your salary or income or whatever. And in the early 20th century, one of the things that Saskatchewan allowed its municipalities to do, these sort of tiny rural areas within the province of Saskatchewan with their own separate governments, was at their own discretion to raise taxes from their constituents in order to actually hire a doctor to treat everybody within the municipality. And this was called the Municipal Doctor Scheme. And we're going to use several historical sources of data, first on physician labor, so the labor force in the province of Saskatchewan, local health outcomes at the municipal level, and economic outcomes at the municipal level as well. And the real contribution that we can make here is we can examine impacts on outcomes for very, very long periods of times. Because these occur in sort of the early 20th century, in the 1920s and the 1930s, we can actually observe sort of the health of these municipalities and the economic outcomes of these municipalities for 50 years after the adoption of these physicians. We're going to specifically employ a difference in differences. So we're going to focus today on the difference in differences. There is a separate part of this paper that looks at contiguous county or contiguous municipality analyses. That's going to be less of an important topic today, but we're going to focus on difference in differences to estimate reduced form effects of the physician adoption on these outcomes of interest, okay? And so as a contribution here, what we're finding in this paper is that we're able to demonstrate the effect of implementing a municipal physician contract on outcomes of interest. So in these rural areas in Saskatchewan, we're basically observing that the physician labor force increases by about 0.5 physicians per year over 30 to 40 years. And this is a highly persistent effect. So it looks like physicians are coming into the communities and they're staying for the length of their careers. We see reductions in deaths per year by about 8% for about 10 or 15 years after the adoption of the physician. Interestingly, sort of new results that we're sort of been producing in the last couple of weeks suggest that these are actually more related to preventative care and chronic care than, say, infectious diseases, which is a little bit of a tweak from the original abstract I put up. And then finally, we're also finding that the physician hiring is actually associated with increases in economic outcomes. So for example, again, we're going to focus mainly on agricultural outcomes here, but 3% increase in the number in the farm area. There's a 5% increase in the improved land in these municipalities, a 6% increase in the number of acres of devoted to wheat, which is the major cash crop in Saskatchewan during the period of time. And we're finding about an 8% increase in the taxable value of all of the property within the municipality. And we're also finding some decreases in the per capita arrears in taxation. So whether or not you're actually late on the tax payments that you need to pay to the municipality, these sort of seem to go down when a physician is adopted into the community. So I guess we'll get into some of the kind of the setup, the methods here, which is sort of first issue here is the policy context and the history of this. So, I know you guys are from Alberta, or are based out of Alberta. This is a much more important slide when I talk to American audiences. I'm from Manitoba as well, so I have a good experience with this. But even more so than today, 1920s prairie provinces were extremely sparsely populated, and the population was largely farmers. So, in the 1930s, Saskatchewan had about 1.5 persons per square kilometer. And, if you, again, for American audiences, this is really useful. There's about 35 persons per square kilometer today in the United States. So highly sparsely populated, which is problem number one for physicians, because it means that you don't, it's hard to actually get a full clinical practice if, for example, you're in a rural area. There's just there's not a critical mass of people to a certain extent. But the other major problem with Saskatchewan at the time was that in 1929, the Dust Bowl hit the prairies and basically completely devastated the economy. So net farming income dropped from about 363 million in 1928 to about 11 million in 1933. So there were a lot of very, very poor people living in Saskatchewan during the period of time that we're examining. And the result of both of these things was that basically doctors did not get paid well to work in rural areas. So, doctors would try and set up practices in the area, and at least the anecdotal evidence from the time is that, sometimes they got paid like 50 cents on the dollar in order to get, when they saw patients in the area, just because patients didn't have the money and there weren't enough patients to sort of produce a practice. And this meant there was a large exodus, especially in the 1920s and 1930s, from rural areas in Saskatchewan. So this was already a place that was very underserviced to begin with, but basically the Dust Bowl made it much, much worse. And so as a result of this, the government of Saskatchewan, the province of Saskatchewan, actually passed this Rural Municipality Act of 1928 to 1929, although municipal physicians were being hired earlier. And this basically allowed municipalities to pay physicians for local care. So this created specific legislation that ensured that these municipal governments could basically levy taxes on their local constituents in order to pay a salary to a doctor for a year. And the doctor would treat everybody within the municipality for free, at least at point of care. And this was actually a relatively successful program. So by 1944, the programs covered about 30% of the rural populations in Saskatchewan. So a very high proportion of people had access to a physician through this program. And it was so successful that it was actually adopted by several municipalities in Manitoba, municipalities or counties within Manitoba in 1939, and was actually a very sort of widely known program in the sense that, there were earlier attempts in the United States to set up sort of more universal coverage for patients. And one of the things that was done was actually, FDR, Roosevelt's original failed federal attempt at national health insurance was at least partially inspired by these programs in Saskatchewan. And so, by the 1940s, though, basically, Tommy Douglas had arrived on the scene, and there was a bunch of other programs being set up in place by the government of Saskatchewan in order to sort of provide optional coverage and sort of access to physicians, which led to several provincial level payment schemes. And so the end of the story here is that this was sort of an act and an intervention that really happened in the earlier part of the 20th century, really from 1910 to about 1945. And these MDs really did a lot of like the primary preventative care. So this is actually one of our sort of show and tell from one of our data sets. We basically have all of the contract information for all municipal MDs in the province of Saskatchewan for 1933, 1934, 1940, and 1941. And so this is an example of one of the archival documents that we have. And so, for example, this is the RM of Fillmore 96, who employed a physician named C. Scribner, who started in 1931 and was paid a salary of $3,500 and basically provided all medical services within the actual RM of Fillmore, except for sort of major operations. And again, this is very, very common for a lot of these places to employ these physicians for primary care. Let's talk a little bit about data here. So we're going to use a couple of data sets. The first data set that we're going to use is a data set on physician labor force outcomes that we've created, again, from archival sort of records. So the College of Physicians and Surgeons of Saskatchewan was very kind enough to let me come to look at their archives. And basically they have cards. So this is a card for Saskatoon, for example, with the list of all the doctors within the province by their sort of community and the dates that they practice within that community. And this actually goes back to 1889, although we think that probably the data is a little bit sparse earlier on for a number of reasons. And so we're sort of we think that we get legitimate capture of basically all of the physicians within the province of Saskatchewan from about 1910 or 1920 onwards to 1990. And so again, allows us at an annual level to examine really long-term outcomes of sort of physician labor force outcomes. We're interested really in three types of outcomes for physician labor force. So we're interested basically in sort of the stock and the flow of physicians within these communities. So the first one is the total number of physicians in a municipality in a given year. So this is kind of like the stock of the physicians, the number of physicians within a rural municipality. We're interested in the number of starting physicians. So again, a flow, I start in, Fillmore or whatever, or Saskatoon, and that counts as me starting during that period. And then the number of leaving physicians as well is another sort of flow measure here that we're trying to look at, where we're sort of seeing whether or not, these physicians are actually leaving. So that's the physician labor force outcomes. We have additional health outcomes, again, sourced largely from archival data. So we have public health reports on mortality at municipal and town level. We're going to focus today on the municipal levels, although the town levels are actually more, have stronger relationships that back up sort of the results that I'm going to show you. We're going to separate this into three major types of outcomes. The first one is sort of general health outcomes. And so again, we're arbitrarily grouping this, as deaths, births, maternal mortality, so the number of deaths, for mothers in birth, infant mortality, and just as kind of like a check, accidents. We don't expect that accidents should have any sort of relationship to the number of doctors with, or the fact that there's a doctor within a community, but as a check. We're going to look at infectious disease outcomes. So these are specifically deaths due to tuberculosis, influenza, pneumonia, diphtheria, and enteritis. And the reason why I've outlined diphtheria is because among all of these diseases, this is really the one with an actual treatment that exists, which is a vaccine. So diphtheria had a vaccine at this period of time. And so one of the effective things that doctors could do is preventative care by preventing diphtheria. The rest of these diseases are, to a certain extent, less treatable by physicians at the time. So this is also a period when some antibiotics are coming into play, but they're very expensive and difficult to source for a lot of people. And then finally, we're going to look at chronic disease outcomes. So we're going to look at deaths due to cancer, heart disease, stroke, nephritis, which is, in all likelihood, from what we can gather from archival documents, essentially congestive heart failure, how congestive heart failure was described at the time, diabetes, and arteriosclerosis. And again, in a lot of these death outcomes for these chronic diseases, to point this out, there aren't a whole lot of really great treatments. There are some during this period, but they're quite limited. And so, especially with chronic disease outcomes, one of the things that we think is going on is preventative care rather than sort of active care driving our results. These public health reports are annual from 1925 to 1944. And then we're going to look at economic outcomes. So again, archival data. So we have municipal level census data for every 5 years from 1916 to 1971. So the census, they're sort of public document census PDFs that you can just pull off of any library website. Every 10 years. And in addition to that, the prairie provinces had basically a census every 5 years as well that sort of filled in these gaps for every 5 years. We're going to look at two major things with the census data. We're going to look at farm productivity. And to an arbitrary extent, we're sort of looking at a couple of outcomes. There are quite a number of outcomes in these data. But these ones we're going to look at are total farming area, the total improved land that exists, the total land for field crops, and the total acres of wheat. The reason for the total acres of wheat, again, is that this is the major cash crop in Saskatchewan during the period of time, and suggests that, if people are sort of growing more wheat, they're doing so because they're trying to make themselves better off economically, and so can sort of feel able to do that. The other interesting thing about this data is we can also look at farm ownership. So we can actually look at sort of the total number of farm occupiers, the number of families who are on a farm at the period of time, but we can actually look at sort of how farms are allocated. So we can look at the total number of owners. This is like, I own the farm. But it is very common during this period of time to actually rent land. And so we can look at tenants as well as part owners. And then finally, to back some of that up, we're going to look at municipal tax data, again, at the annual level from about 1919 to 1928. And there's a big gap in this data, unfortunately. But we're going to then look at this from 1944 to 1954. And the three really interesting outcomes we think are here are this assessed value. So this is basically the total value of all of the property within the actual municipality in a year. And so this is the amount that the municipal government thinks is taxable, sort of a reflection of the value of the economic value within the community. We can also look at the total taxation arrears and the number of unpaid arrears. So arrears basically are late payments on the taxes, again, sort of a sign of financial distress within the community, as well as unpaid arrears, which is really a sign of financial distress. So you can be in arrears for your taxes during a year as long as you pay them, by the end of the year. But if those arrears are unpaid, it's suggestive that really the community is having a hard time paying the taxes that are being levied on it. And so these are sort of signs of sort of financial distress and kind of the economic output of the community as a result. So we have a very basic econometric strategy. We're going to use local projection difference and differences estimation strategy for all of our outcomes, except for the municipal tax data because of those large gaps in observations. In the case of the municipal tax data, we're going to use a classic two-way fixed effects. The way that we're going to sort of provide some more assurances about those results is that we're actually going to use contiguous matched counties. I'm not going to go exactly into these results because this tax data, while interesting, is sort of a less important thing for this presentation. But the basics of the difference in difference here is that we're going to compare adopter municipalities, so municipalities that actually hired a municipal physician or adopted a contract for a municipal physician. And we're going to see how they compare to control group, which is essentially non-adopters of a municipal physician contract. We're going to plot our events. So for the most part, the results in this presentation are going to be event studies. So we're going to look at sort of the yearly or every 5 yearly effects leading up to the point of adoption, the pre-trends essentially. In some cases, that's sort of 3 years before adoption or 10 years before adoption, up to 10 years before adoption. And then we're going to look at post trends. And again, sort of depending on the outcome, this is going to be about 5 to 50 years of post trends. So we can actually look at a really long time series of post trends after the adoption of the municipal physician. We're going to show a lot of these events. We will provide overall DID estimates within the actual graphs themselves. Okay. And, from an economist perspective, causality rests really on 2 kind of assumptions. So the first one is a parallel trends assumption or a no anticipation assumption, basically that these communities are not going to be able to trend differently in terms of their outcomes before the adoption of the physician. We'll sort of come back to that assumption later because some of that may be too strong for some of the results that I show. And the other one is no simultaneous intervention. So the other thing that we have to sort of be wary about is whether or not the municipality is actually adopting other things at the same time. And while you can sort of say that there's a reduced form effect of the physician entering the community, it becomes a little bit more messy if we also think there's simultaneous interventions going on as well. So a couple of results here. So again, this is sort of a drop plot of the year of the first adoption within a municipality. And so this is sort of ranges from 1915 to 1940. And so like we sort of said, municipalities within Saskatchewan were actually adopting these municipal physicians and programs even before 1920. And so there were municipal physicians in communities in 1915. But the vast majority of these adoptions occurred really in the 1930s, again, probably triggered by the Dust Bowl. So this really starts to ramp up around 1929, 1930. And sort of, 8 to 10 municipalities per year were adopting municipal physicians in order to provide services for the community. The geography of this, though, is relatively widespread. So really, this is a map of Saskatchewan here. Alberta's sister province, obviously, and all of these colored municipalities are areas where a physician was actually hired, and the color corresponds to date. And again, like we sort of said, the vast majority of these are sort of being hired around 1930 to 1935. But at least from a geographic perspective, this was a relatively widespread program. So a lot of these communities really did adopt. So let's talk about sort of our first kind of results here. So this really is the first kind of result, which is effects of this program on physician access and retention. So this graph up here on the top is essentially the stock of the number of MDs within a rural municipality. And the 2 graphs on the bottom here are the flows of the number of starting MDs. So this is an MD entering a community and an MD leaving community. So this is MD exiting the community. And the takeaway really here is a couple things here. So the first one is, again, to kind of orient you here, basically at time zero, the municipal physician is adopted into the community or hired into the community. The pre-trend sort of track the outcomes of sort of the number of MDs within the community for up to 10 years prior to the adoption. And this is relative to a control group of counties again, right? So these estimates are basically our treatment counties of adopters versus the control groups of non-adopters. And one of the things to take away from this is there are some anticipatory effects in all of these graphs. So right around the time, right in the year before the municipal physician contract is hired, there's basically a big drop in the number of total MDs, for example, in the community, and the number of starting MDs and the number of leaving MDs, interestingly. But the overall effect here is that there are fewer MDs in the year prior. But what actually happens here is that the municipal physician contract causes a rather large rise in the actual number of total MDs within the community in the year after adoption of the physician. And the more interesting thing is how long this lasts. So this does look to be a fairly long-lived effect. And so up to about 40 years after adoption, you get additional physicians within the community. The overall effect here is a beta of about 0.35. So what that suggests is, again, when a municipal physician contract is signed, the effect is to add another third of a doctor to the community. That may seem a little weird, but that's actually about a 50% increase in the number of MDs that are just sort of on average in these municipal communities at any given point during the time period that we're examining. So it's a relatively large effect. It's a relatively large effect on base. The other interesting thing here is that this sort of length of time that these physicians are kind of lasting within the community does actually seem to be consistent with kind of the lifespan of a physician. So this is about 30 years of practice, 30 to 40 years of practice. And these physicians are staying. The other sort of, again, interesting aspects of this, so this is sort of, again, the stock of physicians within the community, the flows also actually quite interestingly sort of change as well. And so while the number of starting MDs really doesn't have an overall effect except in the first kind of couple of months, the number of leaving MDs actually sort of changes as we get about 5 or 10 years out. So there maybe is some increase in the number of leaving MDs right around the sort of 5-year period after adoption of a municipal physician. But if you last that 5 years, basically there's a reduced probability of the physician leaving. And again, it's about a negative 0.2, probability that the physician leaves the community. And so again, this gives us a couple of interesting kind of outcomes. The first one is, of course, that, you can see the dynamics of getting one of these physicians into the community. It actually lasts a really long time. And it's not just that the physician stays in the community, it does look like it reduces the number of leaving MDs as well. And sort of you can think of this as kind of like you need a critical mass of physicians because, I don't want to work on weekends, or, I need to sort of pass my patients off to colleagues, blah, blah, blah. And so there is some aspect of this that suggests that, you get another physician into a community, it actually reduces the number of leaving MDs as well. But the other important thing of this is that this is essentially our first stage effect. So this is telling us that the adoption of a municipal physician contract actually results in another, in a certain amount of physicians actually entering a community, which in turn should improve access to healthcare. And so that gets us into our second set of results here, which are the general health outcomes here. And so the general health outcomes here really are also relatively interesting. So in particular, there seems to be this decline in births and decline in deaths, although there doesn't seem to be any sort of effect on maternal mortality, the number of stillbirths, which are essentially, abortions, infant mortality, or accidents. These are all sort of very zero null effects. But the effect is to actually reduce deaths by about 8%. So this beta of 1.3 is about 8% of the total deaths within an actual community within a year. The number of births is about a 3% reduction in the number of births. And again, the births thing is also something that suggests that maybe what these physicians are doing is more preventative care. So this is actually also a time period when a lot of contraception is still prescribed by physicians. This includes like condoms in particular. And so these births may be declining because of that. We're going to sort of support this again with a couple of other results from our other health outcomes here, that this looks to be preventative care more than anything that's happening. And, part of the story here is because of this infectious disease death. So again, to sort of make a comment here. Infectious disease deaths at this time were probably pretty hard to treat. So tuberculosis, for example, really you sent people with tuberculosis to sanatoriums. Influenza and enteritis, these are both sort of usually related to viruses. And then pneumonia, is also can be a virus, but, may be treatable by antibiotics. But antibiotics during this period of time were still relatively rare within Saskatchewan. However, the major effect that we observe here is that there is reductions in the amount of diphtheria deaths by about 0.6 deaths at our point estimate by year 5 after the hire of the MD. And again, the interesting thing about this is, the overall effect is about 0.35. The end effect at year 5 is about 0.6. This is basically 100% reduction in the number of diphtheria deaths. There's about, on average, about 0.6 deaths due to diphtheria within a municipality per year in our observational data. And so this is a relatively large effect. So again, only coming through one of the infectious diseases that we can actually prevent rather than, outright cure. And then again, this gets into kind of the preventive aspect of this care. Again, chronic disease deaths. So again, this is, cancer, heart disease, stroke, nephritis, diabetes, and arteriosclerosis. Again, these are betas that suggest, that, for example, during this period of time, the difference estimate of the effect is about negative 0.43 deaths. Although by the end of the period, we're sort of seeing a reduction in heart disease by about 1 death per municipality. And again, these are actually relatively large effects. So, for example, there's really no effect of cancer, which again is not surprising. There's no effect of stroke, but heart disease is a reduction of about 20%. So this is about a 20% reduction in the number of deaths due to heart disease as a result by the end of this 10-year period. Similarly, with nephritis, we're seeing about a 33% reduction in the number of deaths attributable to nephritis. And all of this is sort of to suggest that basically we think what's going on here is preventative care, because there's not a whole lot of actual interventions that can be done during this period of time. Largely, this is, you need to watch the amount of fluid intake you have. You need to watch, the food that you eat, things like that. And there seems to be some effects that are coming through these chronic diseases, as well as this sort of diphtheria kind of effect that we find, all of which points us towards sort of preventative care. We can move on to productivity outcomes here. How am I doing for time? Okay, we're good. Okay, so we can move on to productivity outcomes here. And so this is just examples of some of the productivity outcomes that we're able to observe. Again, the event analyses are relatively wide in terms of their confidence interval, but there is this general trend, and this general trend is towards the treatment group of communities having better outcomes than the control group of communities. So adopting a municipal physician seems to result in an increase in the total area of the farms in the community by about 5,100 acres. That seems to be, I believe, about a 3% increase in the total number of farm area. The total improved land, as opposed to say idle land or things like that, or unimproved land, goes up by about 4,800 acres, which again is about a 5% increase. There's sort of an improvement in the number of in the number of acres devoted to field crops, which is again goes up by about 5%. And then the areas of wheat, for example, again, the major cash crop in Saskatchewan during this period of time goes up by about 2,700 acres, which is again about a 6% increase in the productivity of these communities. And again, the other thing to really take away from this is that this is not only just a short-term effect, so this is not only over 5 or 10 years, but this really lasts for 30 years. So this is a long-term effect. The other interesting thing is kind of distributional aspects of this. So one of the things that we're actually seeing is that there may be this dip in the number of total farm occupiers as a result of the adoption physician at time 0. It's not statistically significant. It's very sort of small, but total farm owners do actually go down. This is a decrease by about 2% in the number of total farm owners, but the number of farm tenants that exist as a result goes up by about 10%. Again, sort of suggestive that one of the things that might be happening is that there's this kind of insurance aspect to the physician where, if you hurt or harm yourself, you're not going to lose your farm, and so you can take more risks, for example, by renting out land. And then finally, this is the effects on our tax outcomes here. So this is basically the total taxable value within a community during the year. And so this is again a difference in difference estimate here, where we're looking at what the total taxable, how the total taxable value essentially changes as a result in this treatment group of communities relative to the control group of communities. And again, one of the sort of underneath the hood things that we're doing here is we're using contiguous counties in this case because we can't do event analyses because of that gap in the data. But one of the things we're seeing is there's an increase in the total taxable value within treatment communities by about $187,544. And that's about an increase of about 8% of the total value within a community. And again, sort of a 5% increase in the per capita value within a community. And again, we're not seeing a whole lot of effects on the total taxes and arrears. There may be some increase, but really this is not statistically significant. But we are seeing sort of a decline in the number of total arrears that are unpaid per capita, and sort of a very kind of marginally statistically insignificant result in the total arrears unpaid. And so this is about a 5% decline in the number of total arrears unpaid per capita. And so really the conclusions that we're able to draw from this are number one, that sort of the Saskatchewan Municipal Physicians Program is really successful at introducing physicians into rural areas. And it tended to have really long run effects that suggest that if you put a physician in a community, a rural community, and at least they last beyond 5 years, they're going to stay for a relatively long period of time, at least within the context of this historical event. We see this improved stock of local physicians in these rural communities, but we also seem to see these reduced physician exits. So fewer physicians are exiting these communities, especially sort of 10 to 30 years out. We're seeing effects on overall mortality of the physician and on births. And so the channel is less obvious here. And obviously we may have to do some speculation. We do some speculation, at least in this presentation, but this channel really seems to be more through preventative care and sort of prevention of chronic diseases than perhaps treatment of infectious diseases. And again, that's sort of consistent with sort of kind of the technology ability of the physicians at the time. Just there wasn't a whole lot of ways to treat some of these diseases. There were a whole lot of, or at least there were better ways to prevent these diseases. And then we're finding evidence consistent with improved economic outcomes, including farm ownership and tax-related evidence. So it does seem like the value in these communities goes up because of the physician. And all of this points towards this idea that the Saskatchewan Municipal Physicians Program is really associated with access to physicians, better health, and better economic outcomes. And so with that, I think I've gone a little bit over time, but I'm very happy to take any questions that you might have about the talk.
Thank you very much, Dr. Strobel, for this fantastic presentation. We now invite attendees to use the Q&A function on the Zoom software menu to ask their questions, and anyone with further questions after today's webinar is encouraged to email noah@ihe.ca.
And just to reiterate, here are my emails. Certainly, like one of the things that we're very happy to do is to share this data. So we've created this sort of big set of archival historical data, and certainly anybody who's interested in the data, grad students or people who are interested in collaborating, we can by all means drop me an email, and we'd be very happy to kind of discuss sort of sharing the data with you.
I think we can give the attendees a couple of minutes to type in their questions.
Mm-hmm. Maybe no questions today. That's okay. Yeah, so that's a really interesting question. The question is, I'm not sure if you mentioned this, but were the populations in the studied areas changing over time in any way? One of the things that we don't have is a lot of kind of, let's say, control data, for example. We do have some evidence on immigration status, although it isn't very good for events, so it's only very sparse data. So, for example, it's like I believe it's in 1915 and 1945 and 1955. There is a couple of immigration waves that are occurring during this time, especially right before when these municipal schemes kind of went into place. So lots of Ukrainian and European immigrants. And at least anecdotally, it seems like that actually might be one of the impetuses for hiring the municipal physician. So especially people were coming a lot from England and had access to really good physicians in England at the time, for the time. And were just very shocked by the idea that they couldn't get very good healthcare in rural areas within Saskatchewan where they moved to. And so that was one of the reasons that may have led to an adoption. I think one of the things that we're sort of doing at this point is going through robustness checks, and it might be a good idea just to sort of see what kind of the composition of these communities is at certain points in time. That being said, there was also a lot of sort of internal immigration within Saskatchewan during the period of time as well, because especially in the 1930s, there was a lot of movement because of the Dust Bowl. There isn't, so the results that we've shown are robust to controlling for population, so like size of the communities within the municipality. But there was some emigration within the province of Saskatchewan as a result of this as well. And then, of course, we also overlap with World War II. So like 1940s was World War II. And so there are some sort of aspects of, say, like the demographics changing in terms of like male persons within these communities at the time. Again, we're not seeing a whole lot of, problems occurring as a result of controlling for those outcomes. But those are aspects that are going on during this period. Thank you for the question. Yeah. So the impression that I get from a lot of these, so the question is, were there other interventions employed in Saskatchewan aside from recruiting physicians to municipalities? For example, physicians traveling to rural communities for a day or two per month. My understanding is that was certainly not a very large aspect of this. Now, that being said, there are certain towns within Saskatchewan where there were physicians just kind of naturally set up. So, for example, there was a group within Swift Current that was relatively large. There was a group within, I believe, Battleford that was relatively large in Prince Albert. And one of the things that municipalities in the area would do would be to hire the physician from that town to travel out into the community. And so to the extent that, for example, like current policies are designed to kind of like, for example, I've done fly-in communities in northern Manitoba, right? They fly me up for a week and then they fly down. I've worked in those kinds of situations. There certainly wasn't a comparable kind of program in place, although there was some travel throughout the province, especially kind of in these local kind of networks around certain rural areas. That being said, the other thing to kind of think about, Saskatchewan is actually a really interesting province. So Saskatchewan also has another sort of simultaneous policy at the time called union hospitals. And one of the things that they set up was essentially like free hospitals, or paid for hospitals by the provincial government, that are also sort of during these 1930s, 1940s kind of period. So medical care really is changing quite a bit during this period of time in Saskatchewan. It's not just sort of the municipal physicians necessarily, but it was a really kind of creative and experimental kind of province in terms of how to deliver healthcare. So hopefully that answers your question.
Okay, thank you very much, Dr. Strobel, for the presentation. And thanks to everyone online for attending. So As I mentioned, anyone with further questions after today's webinar can email noah@ihe.ca. So the topic of the next NOAA seminar is still to be confirmed, but it's presented by IHE's Sasha Van Catholic on March 20th at noon. The topic will be determined at a later date and will be posted on the NOAA Rounds webpage. Please visit noaa.ca to register and subscribe to our mailing list for news on upcoming events. Thank you very much again, and have a great day.